Huh?
So you can take a joke.
You probably could.
That's
We had last year talking about being in the military, and he's like, "Yeah, you see that?" I was like, "No, I took a shot."
If he gets too stressed out, just tell him there's a nice big recliner and ice cream waiting for him at his job. Where's Jason? Where he needs to be here tonight. Therapeutic communication.
It's fun.
Okay. What is communication?
Interaction between two other people or multiple people.
Okay. What else?
Be nonverbal, verbal, written.
a message.
Yeah. We're conveying some kind of idea. It gets sent, the person acknowledges, and so forth. Creation of shared meaning of the mind through an exchange of common symbols. Okay. How much communication is actually verbal?
About 10%.
10%? Yeah. 90% of communication is nonverbal. So, and that's a big thing to notice is when you're out there, you become very astute observers of people, because people are going to tell you one thing, and obviously you're looking for signs, symptoms, and everything else, and you're looking at them, you're kind of listening, but you're looking them up and down, saying, well, do you have this? And then you're looking at body posture, and how are they presenting towards you, and then you're kind of taking in what they're saying to you, and it's like, does all this kind of match up? So here we have the sender. Here we have the receiver. Thought. Encoded. I like how they put this encoded message. Decoded. Well, it's actually kind of true when you think about it. How many times do we, especially in the politically correct world, that is a perfect example of encoded messages right there. And that's one of the things you also got to kind of run into is when you're out there, obviously, how do you say things?
Has a lot of adipose tissue.
Yes, exactly.
Yeah.
Hyperbarically challenged.
Freaking huge.
There's always that. Rectal cranial inversion. Little things like that. But yeah, no, you're right. We for some odd reason, especially with our society, we don't want to say things bluntly because obviously we don't want to upset people and so forth. So we send in little encoded messages, even when we're talking to our partner or something of, whatever the case may be of, I don't know, or they get the caught or something like that, or you need something you don't want the other person to acknowledge. Can you go grab the narcs out when you're really saying, you know what, I need the Versetta, we're going to have to put this guy down, kind of a thing. Or the other one, actually, we used to do years ago is we're done talking. As soon as usually by that point, we have somebody who's just getting obnoxious, combative, everybody would kind of fan out, and at one point somebody say, okay, we're done talking. Everybody jumps. So, but yeah, we have those little encoded messages. And of course, we get feedback, basically saying, yes, I understood, received, I'm sending it back. And usually it's back in another encoded message. So, failures of communication, prejudice. How does prejudice affect communication?
You just don't listen to what they say.
Yeah,
You don't care.
You don't care at that point.
Yeah, you're not going to validate it. You're not going to validate what they're saying because you already have this preconceived notion of they're this type of person. Right. Lack of privacy.
Some people don't want to talk to you if there's other people around.
Yeah. There's a lot of issues you're going to run into that you just can't say out in the open or just around certain people.
Like 16-year-old pregnant with mom in the room, with dad in the room.
Yeah. Or actually even worse, 16-year-old with venereal disease with mom and dad in the room.
Yeah.
That's a interesting one. External distractions.
Don't be seen, noise,
Everything.
everything.
Cars getting cut apart. You're in the car trying to do things,
Cut your helmet off.
that's a little irritating. So, internal distractions.
Not daydreaming, but you're thinking of something else.
I've been up for 20 hours. I'm really hungry right now. What are those other internal distractions?
I have a
You
headache.
get like a
Huh?
I have a headache.
I have a headache. I really need to go to the bathroom. Yeah.
That's what you asked them. Hey, can I use your restroom?
That's creating an external distraction, Ethan. And that's kind of falls into lack of privacy.
And then prejudice, I'm pretty sure.
I'll find a prejudice for Ethan here in a minute. So, well, yeah, internal distractions. Like I've told you before, this is can be a very emotionally charged job. So of course, you're going out and you've already got some personal issues. You go out there, and it's not like, like for a lot of us, we go, like for me now, I go sit and hide in my office. I have personal issues, fine, I am hiding in my office. I can tune out the rest of the world. You don't really get that because you still have to actually engage with people all the time, but all that stuff's still going on. And can be a really big internal distraction. Or maybe it's the pediatric arrest you just ran beforehand, and you're running into this guy who says, yeah, my feet hurt because I've been walking too much all day. That can be an internal distraction because you're like, I'm trying to process something else that's like up here, and you're telling me this? Think that would create a prejudice?
Very much. So.
Yeah.
So you're homeless, you now choose.
Most people, take several years to get where you are.
I saw that issue.
Yeah, I know. That's okay. So anyway, it's just a homeless guy, not a real patient. Well, he's homeless, but homeless people get sick too. In fact, I remember taking this one guy to St. David's, and it's just, this lady had a psych history, about 3 pages long, and I was like, but she's presenting to this, and I remember the charge nurse was like, well, crazy people get sick too. It happens, but the thing is, it's just they don't want you to, again, blow that off saying, oh, you're just homeless, you're just doing this. Just understand they get sick like everybody else.
This is going to be hard to figure out what it is.
Depends.
If they've got a ton of stuff going on with them.
That-
Crazy, you can't talk the right way.
That's tough. That's very tough. So I told you about the schizophrenic, right? Down in Austin, used to go rearrange stuff at Taco Cabana, pull the trash out and stuff. He actually had long diabetic history. So it was always the trick thing is this a schizophrenia or is this his diabetes?
Right.
And then if it is diabetes, is he maintaining, and he's homeless, how well is he taking care of his diabetes?
Right.
So you got a whole multitude of how do I sift, through all this.
Be like him, just serve you Taco Bell.
Huh?
He served you Taco Bell, and you say, hey, you just go through all.
It's difficult. It's difficult. I mean, the guy is, like I said, the guy would sit there and talk to you, and then you just watch him just wander and go off a different direction. He was actually, you could tell, he was almost trying to keep up with the conversation, but his mind would just go here. Yeah, I mean, it was just kind of one of those things. It's just like, what, we just got to take you in and, get all the blood work and stuff. Anyway, helpful traits to kind of help you through. Obviously, you got to have a genuine liking of people. I hope you have a genuine liking of people. If not, this is, why are you here? We need to go talk about. I would really like to know. So obviously this is a desire to be part of a helping profession. Understanding of human strengths and weaknesses. Understand this is going to be very subjective from person to person. Everybody has their breaking point, especially mentally and physically, and everybody is going to be so different. I mean, I've seen some people that were. Cops, all of a sudden, they just saw the wrong thing wrong. I remember, I can think of one cop, we had actually a SIDS child, broke, done, but I mean, it's just everybody's going to have different breaking points for different things, so just kind of remember and try not to get too caught up because I have seen a lot of other people say, well, I understand why that person got upset about it, there could have been a series of things going on, and boom, that one just took them over the edge, or maybe this was that one trigger. I mean, who knows? And the same thing with strengths and weaknesses too. Depending on how they handle pain or what their experience with pain is. I mean, I've seen people that got injected from cars come walking up to me, and I can think of this one girl. She was all. I mean, she acted like she was 5 years old, and she was like, I split my lip over a car accident. It's like, how do we? Everybody, like I said, everybody's going to take a different twist, so you just got to remember that. Not everybody, we always kind of sit there and say, oh yeah, there's this thing called common sense, we're on a common page. No, it doesn't exist at all. Just chuck that out. Common sense is a common, and we're not all on the same page of reality. So. Empathy, obviously empathizing obviously for their situation, what's going on. Like I said, you're going to run into, it's like I said, everybody's going to handle things differently, and people are going to react to things differently. And that can be because of multiple reasons. It can be financial reasons, family reasons, cultural background, and so forth. And the last year is patience and flexibility. I mean, you have to be patient with people. Like I said, because everybody's going to be different. Okay? And you have to be flexible because, like I said, just because of all the diverse backgrounds and experiences, you have to kind of learn to adapt with them as you're going along. By the way, you guys met Dr. Greenberg yet? Yeah. Yeah, he he actually put this together, so if you want to talk to him about the Star Trek stuff, feel free. His email's at the end of the slideshow, so if you want to email him, I always encourage students every semester, email Dr. Greenberg after you see this slideshow, and you can ask him all the Star Trek questions you want. Oh, I got a quick side note about Dr. Greenberg, by the way. So they had a meeting upstairs last semester over with the DEA changes. DEA was here, and we had people from Austin, Wilco, Marble Falls, and everything else. And they actually had a camera going, and they were recording the whole conversation with. Anyway, I'm kind of looking in, and it's actually sitting pointing right at Greenberg. And he just looks at me and goes, and I'm sort of thinking, he's just getting this recorded. He's like, he didn't even care anymore at that point. But yeah, Greenberg's funny.
Who is he? What?
He's a medical director for the ER. Yeah. And like under him falls like Jarvis, who overs us, and below him is McGraw. And I think it's going to actually get split up even more. But he's, head honcho. Okay, building a trust and rapport. Understand first impressions are critical. Best advice I can give you, try to come in neutral. Kind of more of a neutral stance or neutral demeanor. Because like I said, depending on what's going on, how they're feeling, how they're acting, all that stuff can change their perception of you just walking in the door. That way it's kind of like, obviously if you're scared, you don't want to come in, overbearing and thinking, oh yeah, I'm done at that point. Or if they're agitated, you want to come in and make them more agitated or make them feel more depressed, whatever the case may be. So a lot of times I just say, just come in just very neutral. Come in very neutral, find out what's going on with the patient, and then you can kind of start adapting your persona to what's going on at that point. Use the patient's name. From a psychological perspective, people love to hear their name. Just kind of let you know. Address patients professionally and appropriately. Like I was telling before, some people are going to require to be called Mr. Johnson, Mrs. Johnson, and some people are going to be like, no, you can just call me Tom, whatever the case may be.
And usually that's an older generational thing, the Mr. and Mrs. and...
But the funny part is that generation's fading out.
It is.
Because, a lot of the 60s generation is
But I live near Sun City, so...
Yeah. Yes, I understand.
Yeah. It's a whole new ball of wax out there.
Yeah. There's like probably about 70s, 80s that still wants to be called, Mr. and Mrs. And then you've got right behind them is actually 60s generation. And they're like, okay, calling you by their first name. So everybody's going to be a little bit different. Modulate your voice. I really wish I could just give a class on how to modulate your voice and actually get some voice actors. Because you want to be able to, like I said, that's part of that communication. It's not just hearing what you're saying, but that modulation of, animals actually rely on modulation. Now, obviously, the way you talk to an animal, how much they actually interpret and comprehend what you're saying is kind of, depending on animal to animal, but the modulation of the voice is what they rely upon the most. So, if you come in, with a kind of more baritone, it's like, hi, what's your problem today? So, like I said, just be careful of that modulation and the flexation of, the fluctuations of your voice. So, and again, like I said, use your inflections to demonstrate concern, confidence, and assurance. Again, like I said, it's one of those, you want to just, even if, honestly, even if you are having a bad day, even if you're not feeling up to it, you want to at least convey that you are. Or if you're relatively new at talking to people or talking up in a big, indoor voice, it's just one of those things you kind of want to be able to kind of turn on that switch and say, okay, yes, now I can talk and da-da-da-da-da, then all of a sudden you can kind of go back to where you were. So just understand it's almost kind of like, that professional demeanor kind of incorporates that voice, also incorporates your, body language and so forth. Explain your actions, concerns the patient using words he or she understands. It's very easy to get caught up in using all of our medical terminology, and of course they're not going to understand it. So sometimes it's trying to figure out, looking around. Like I'll look around a lot of houses and places I'm in to kind of see who they are, what their background is. Maybe I can figure out what they did for a living. And if I can find a way to relate that in terms they understand, that helps a lot. So be kind, keep a calm facial expression. You know, nobody's going to respond. You know, trust me, patients don't like when you come in like this. It really doesn't work, believe me. So choose appropriate communication style for the situation. This is just going to take a lot of practice. And watch your preceptors and how they do it. And part of it is, really a big part of it is how to use your own persona to your advantage. And everybody's going to have their own little advantages versus the other person. You know, I mean, I could think of one guy I used to work with. I mean, he could literally come up. I remember this one girl, she was just, you know, playing dead and all this other business. And, you know, we got 911, everybody and the brother, and the way he just did, he just got up, he says, walked up to her, I know you're faking, now you need to get up and get to the cot. And he walked away, and she did it. I couldn't get away with something like that, you know, but he had that persona, he could use his persona like that for that situation. So just kind of understand, acknowledging your own strengths and weaknesses. Don't worry if you're not the person next to you or your preceptor. Figure out what works, how you can use what you have to your advantage. Okay, first impressions. Are first impressions important?
Yes.
Okay. So critical to communications. Again, like I said, first, when you come walking in the door, how you're acting, how you're looking, that's how they think you're going to be towards them. They're already putting that mental image of who you are right from the get-go. You know, some people say, well, yeah, people are being judgmental. Well, yeah, they are. We all do it. And that's just kind of reality. So personal appearance, depending on where you are, it's going to kind of vary. I mean, you go down south, you're going to see a lot of cops, firefighter medics, I mean, with sleeve tattoos. You know, I've seen, you know, come in with orange hair. No big deal. Obviously, up here, that wouldn't go over too well. So just understand, you know, personal appearances kind of vary. But like I said, you don't want to come off smelling bad. You don't want to come off looking bad. You know, you come in, you know, looking nasty, you know, and so forth. Uniform, please take care of your uniform. You know, I mean, even if I were the guy with sleeve tattoos, like I said, me personally, I don't care about that stuff, but at least take care of your uniform, take care of your clothes coming in the door. You know, I don't know how you would feel, but if some guy coming walking in and you saw, like, you know, faded bloodstains on their shirt, I'd be like, I don't know if I want that guy touching me. But physical fitness, again, to kind of harp on that one, it's first. Actually, this was a very interesting one. I went to. You guys ever heard of NAMC? Yeah, National Association of EMS Educators. Well, they kind of did this really interesting thing. They actually pulled a couple people aside, and two people randomly, and then they had the two instructors there, and they said, well, looking at the two, who do you think would be the most appropriate and would fit this role? And of course, we're just kind of like, well, yeah, we're going with this person because they got the three-piece suit, this, that, and the other. And it's like, yeah, this was just kind of a couple of young people. Yeah, they're good-looking young people and so forth. A lot of people that they found out were looking at the young, healthier people and say, well, that person knows what they're doing. It was kind of those really interesting twists versus the person, you know, like I said, again, older guy, you know, and they're like, well, maybe he really doesn't. He just kind of looks older. So just kind of understand that is there, you know, so just kind of keep that in the back of your mind.
Like, don't label somebody just because they're older doing this, that they know everything, or have been doing it for a long time.
Well, it's kind of, I think a lot of it just kind of there was something that's to be said about, they saying the younger, better looking and shaped person got more recognition as being somebody who was more knowledgeable, knew more versus somebody who wasn't. You know, and that's just, I mean, if you kind of actually go through, I mean, if you actually go, like, even with your jobs and stuff, I mean, just kind of see how much that works. You know, I mean, I've seen that happen a lot with this kind of job. It's like, you know, maybe get the more attractive female, she keeps herself well maintained. She's not as smart as the other female medic that may not do as much, but people will acknowledge her and go to her, or even with a guy. I've seen that happen with the guys too, you know, versus like maybe an older guy they may not, because maybe he's got kind of a big scruffy mustache versus the other guy isn't. They're about the same, I mean, it's the same age, but he's more physically fit. So, I mean, it's kind of I don't know if it's more of a biological thing or just something we kind of ingrained, you know, because of our, you always got to have this, you know, perfect physique culture, but just understand that's there. But, I mean, if anything, I'd say just physical fitness is do it because of the job, really. Because you can hurt your back really bad. my old partner in, I told you about my old partner in Austin. Scott, yeah. Yeah, he's out on OJI, here to back again. So he gets to go to physical therapy and all that business. So calm, capable, trustworthy demeanor. Sometimes it's really best just to come in and thinking, I am this person, you know, or think about what would this ideal person look like, and just said, well, I'm going to act this role out. You know, like I said, I just put it as kind of my professional face, or, you know, as I sometimes say, I'm getting into character, you know, kind of thing. You know, so calm, capable, trustworthy, and so forth. And like I said, you just kind of develop that. And like I said, also watch your facial expressions. You know, I have a real bad habit of this. People don't like that too much. You know, especially when they're actually sick or ill or something, or you're doing this, you're kind of like, because I'll hear something in the back or somebody make some dumb comment, and I'll be like, what are you doing? And they're thinking I'm talking to this person or reacting to what they're saying. You know, I'll be like, hey, why don't we sit there and put this on the seat collar? And I'm thinking, they're sick. What are you doing? But just careful of this. Oh, or actually, I actually had somebody catch me on this. I had a real bad habit of doing this. You know. Oh, you know, because and actually it actually finally caught up to me, because one time this poor girl, she was like 21 over at 6th Street. Some girl came up to her with a high heel and hit her on the forehead. It split. So of course they're all doing this thing, and I'm like, hey, how you doing? Ow! Next thing you know, she's all bawling into tears. I'm like, yeah, you know.
Like a 21-year-old girl.
Yeah, but again, like I said, you don't really think about that. You're like, you know. Stance and gait. Again, like I said, be conscious of your stance and gait. Like I said, some people can get away with, you know, having their arms crossed or the hands on their hips. Some people can't. It's just trying to figure out what works for you. And like I said, you'll figure it out eventually. You just got to kind of play with it with different patients. And some things are going to be more appropriate with others. So just be kind of cognizant of that with your patient when you're dealing with them. Obviously, consideration for the patient. You want to be able to gain their trust as you're coming in. You don't want to not gain their trust and then try to build their trust and then try to figure out what's going on, because now you've just got a big roadblock you have to go overcome. Addressing the patient, again, be professional, be appropriate. The big thing I'll just point out here is stay away from the hi, sweeties. My name is Joe Bob. I'm here to help. You don't want to sound too cliche. Obviously, if you sound too cliche, they're going to kind of pick up on this. Well, actually, when this is said, we don't say the sir part.
Just once.
Right.
Huh?
Just once. I want to see you try it just once.
You can do anything once.
Sir, shut up. Go give me shit. I'm tired. Just once.
You know what? I'm not going to say it doesn't happen, but it does. And oh, yeah. Well, again, here's reality. I know we really want to emphasize being professional, but you have to understand you are human. And when you're tired and you're having a tough day, you're going to slip. You're going to slip. It's just making sure. It's like, oh, I slipped. Let's make sure I don't do anything else. Or if I do slip, let's either, one, catch myself, or two, if I do slip, let's not say something I'm really going to regret. You know?
You go to a nursing home and an old lady punches you in the face and you're like, I literally almost killed her because you get hit in the face and what's your first response? You want to hit her back? Not me. It was the medic I was working with. He was like, I almost literally just punched her in the face.
Yeah. Yeah. People are going to try and hit you. You know, or.
Joins.
So, I mean, it's just, you know, I've told you, I haven't been drinking, and sometimes I'd slip up and say, so you normally smell like a brewery? You know. Yeah, you gotta be careful with that. People don't, So, like I said, the big thing I'm going to tell you with that, when you kind of get in those kind of situations, is just remember, sometimes it's don't let the situation get under your skin, and don't let the patient get under your skin. You know, you got to be able to kind of push that out. You know, I wouldn't say compartmentalize it, but definitely push it out. You know. But yeah, just don't sound too cliche. You know, don't say, hey, honey, hey, sweetie, all that business. So just be polite. Be polite and respectful. And the thing is, I mean, if somebody is, even if they don't deserve it or you feel they don't, you can be their friend. If not, you can just be professional with them and just leave it at that. You know, like I said, if they're just going to be obnoxious, let them be obnoxious. But like I said, those kind of people want you to engage. They want to get you riled up. They want to get you this. And like I said, we'll talk about tricks to get around that one. So again, just demonstrate calm, confidence, reassurance, moderate volume level and moderate pace. Practice. This is just one of those practice things. And watch other people and how they do it. I mean, that's how I learned a lot of what I was doing. I watched other people do it, even like with other teaching. I looked at other instructors. How did they do it? What sounded good? What didn't sound good? And started thinking, well, can I incorporate this or can I not incorporate this? Okay, demonstrate concern and compassion. They're going to pick up a lot faster if you don't care, really quick. You don't have to be overly, down on your knees weeping with them, but obviously, like I said, they're going to pick up. People will pick up on negatives a lot faster than they will on positives. So, just try to keep an eye on the negative behaviors. Watch your nonverbal communication signals. Like this one. Yeah. Hey partner, I forgot. What's that drug we should give to someone having a heart attack? You know what the other one is you're supposed to avoid? Oops. Yeah, you shouldn't say oops around a patient.
Ouch.
But what's that drug we should give somebody of a heart attack? Da 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 da. Yeah. Just remember, you're having legitimate conversation, but to them it's a totally different. They're interpreting in a totally different manner. Well, son, you deserve to get shot if you go around holding up banks. Yeah, you should kind of see these are just more, that's more of just a smart ass remark. And like I said, obviously they're saying something to you at that point. Ma'am, if you don't want to go to the hospital, let me know so I can go back to bed.
Yes, so true.
Yeah, that's actually there's a way around that. If you're just going to here to argue, I'll call the police and I'll let you argue with them. They don't usually like that one. And they really don't like it when you sit there and say, okay, send the PD. And they're like, well, we don't. Too late, you're dealing with them. Yeah, oops. Yeah, I remember at one point when I first started, I remember they had a problem with a guy who used to wear these big old, thick, fake bug eye, costume glasses, make your eyes look real big. And he'd start shuffling through stuff about ready to start IVs on people. And you're like, okay. Okay, I'm going to get this. And of course, patients like. There was actually one point, I remember everybody had little Billy Bob teeth, they come in, hey, what are you doing? No, you can't. I'm sure there are some that really bigger. I'm probably like a Denver. You could probably do that for a little while. Down here, you probably Dallas. I'm sure you could probably do it for a little while.
Houston.
Yeah, the bigger where it's like there's too much going on to worry about this kind of stuff. So maintain facial expressions that support your verbal messages. When you don't want to sit there and say no, yes, kind of a thing. So building trust and rapport, you're going to see this very over and over. Be honest. People don't like it when you lie to them, and even you don't like when people lie to you. So explain in simple words what you're doing. That's key. And actually, with a lot of things, I always say just try to keep it as simple as you can. Warn before you're causing pain. Hey, I'm about to stick you. 1, 2, 3. Let the patient know what to expect. Big thing here is don't be patronizing. It's very easy to be patronizing and condescending and all that. Again, that's the negative stuff you want to keep an eye out for. That's the stuff you want to tuck away, deal with it somewhere else. Choose communication style, appropriate situation. Again, like I said, depending on what you are, you may need to be more of an authority figure. Sometimes you can be very calm and very friendly and chit-chat. Sometimes you're kind of more of that command mode because, patients circling down the drain and you're trying to get 5 people that may not even know each other working together. So, it's all going to change. So just kind of understand and the thing is with tones and expressions, how you set a tone, everybody else will follow. Okay? You'll probably see this in the ER, and you'll see this on calls. If you come into a scene and you see the one guy who's in charge is flipping out, everybody else is going to be chaotic too. And that's one of the things you got to take that person out and reestablish control. So just remember that, how you set the tone is going to trickle down. So remember your interpersonal zones. Slowly move in. That's the best advice I can really give you. Slowly move into your interpersonal zones. Keep it a comfortable distance defined by the patient. You'll be able to tell. Obviously, start getting too close, and they're like, you just watch those little subtle, gestures. Interpersonal space with caution. So, eye levels. Ideally, you want to be kind of on the same eye level as they are with any patient, whether child, adult, whoever. Nobody likes, somebody towering down, staring at them.
That's normal for me.
Huh?
That's normal for me, I'm sure.
So, paramedic stance and posture. Again, like I said, just depending on where you are, what's needed at that point. Compassionate touch, if appropriate. Patient expressions and actions. Patient relocates him or herself. What does that tell you?
Uncomfortable.
If you're too close.
Yeah, don't touch me. I don't want you to touch me. Obviously, expressions of fear, anxiety, and anger. Difficulty speaking with attentiveness. What does that tell you?
Upset, maybe?
Distracted. Frustrated. Obviously, abnormal moods such as depression, sadness, or apathy. That could be a number of things. And that could be a number of things. I mean, that could be, again, psychological. It could be physiological. So, interviewing techniques here. Okay, I think this is on a quiz. What's an open-ended question?
Let the patient respond.
Give me huh?
Explain.
How are you feeling today?
What happened today? What's going on? Something. Okay, it would be a closed ended.
Yes. Your foot hurt?
Yeah, exactly. It's going to answer yes or no. And again, I think I'm saying from the quiz, remember those are the ones that use, especially people who are talking a lot and going over and over. Like I said, it's a good way to get control of the conversation at that point. What do we mean by leading questions?
Kind of giving them their own
Are you having
answer.
some chest pain today?
Didn't you?
Does it feel like, does the pain feel like stabbing pain or something like that where you're...
Your pain is here, right? Or something like that, where you're kind of telling them where it's at or telling them what it is and not letting them come up with their own words.
Yes, it's really what happens is you get fixated on a diagnosis already. You're already convinced this is an MI, chest pain, so you start asking questions. They'll lead them to saying this is an MI versus actually being a little bit more broad to make sure it's not. I mean, we'll kind of do that, or you're sitting there thinking, no, I think it's really this, so I'm going to ask you questions that's going to reinforce what I'm already asking. Let's say you're thinking you've got, some kind of sick, just general nausea. So I just keep focusing on that leads you to that point. So yeah, you're just generally sick, you're okay. You've got an anxiety issue versus, no, actually you're having altered state because maybe you're, dialysis patient haven't been to dialysis in a couple days. But I'm fixated on this one thing, so I lead you to that point. That's a problem with leading questions. You really kind of shoot yourself in the foot with that. One question at a time, ideally, is one question at a time. Let the patient finish before asking the next question. Ideally, yes. Sometimes it's like, hey, you just tell them straight out, I got to ask you a ton of questions, get a ton of information before we get you to the hospital, so just bear with me. Tell them just right out. And we're going to be doing a ton, several things as we're going along here. But that's kind of a yes. Ideally, if we have more time, yes, we want to sit there and just let them talk, ask questions, let them talk, and so forth. So, again, use patient language a patient can understand, and do not allow for interruptions. Generally, no. Depending on what it is, we may have to. Like one thing, one thing I've learned never to do going to an assault call. Never ask what happened. Do you know why? I want to take a guess why.
Because they'll go on and on and on and blame and just...
well, I ran into this person, and then we were just sitting there minding our own business, drinking, and the next thing you know, we're doing shots, and these guys came over and did. Yeah, you just actually kind of created your own monster there. Sometimes on certain situations you want to say, well, are you hurt? Where are you hurt? How did you get hurt? And like I said, kind of keep control of the conversation that way. Oh, let's take a break. Anyway, feedback techniques. Silence. Okay, this is giving the patient time to gather his thoughts and add what has been said. Silence is a good thing. Sometimes people just need, and sometimes usually it's about a good 30 seconds or so. Just give them time to figure it out. And well, the big thing is don't let it get you uncomfortable, because if you get uncomfortable, they'll get uncomfortable. You know, if you're waiting, you know, I mean, you can do something else like, you know, play on your clipboard or start documenting, and you know, but nobody, especially in more volatile situations, you don't want to be pressured to talk. You know, do you think somebody else is going to want to? Reflection to check your understanding to what and to reassure the speaker and echo his message. Just again, so the problem is the pain is from that knife sticking out of your back. You know, pretty much, I understand what you're saying. I'm saying it back to you to make sure we both understand each other. Facilitation, again, I'm kind of asking questions to kind of get you more. It's like, okay, so you're going down the street and a guy hits you in the face, and then what happened next? So you have a wound on your belly, and it went from what happened from there. You know, we want to keep this going. We want to keep this going. Empathy, relate to the patient on a personal basis, but not too personal. Again, the key word here is not too personal. Let your body language show that you understand, so the patient feels more accepted, open to talking. And like I said, you know, this is one of those, again, part of our profession is putting all judgments aside and everybody's just kind of on an equal page. But sometimes it's just kind of getting in that thing of just being more inquisitive, showing that you're interested in what they're saying, gets people to talk more. Clarification, ask the patient to help you understand. You know, when you need to confuse, so if I understand you're right, this is what happened. You know, so if I understand you're right, you took about 5 of oxycodone and then you did 1 gram of heroin. You know, or actually one thing, or I mean, because sometimes you don't. And the thing is, with some of these, you be careful with this one because you can sound very rhetorical, and so be careful with that. You know, because I remember one guy, a kid, 19 years old, he did a gram. He was sitting there talking to me how he did a gram of coke. That he was like, wait a minute, you did a gram of coke all evening, and you're having chest pain now. You know, you don't want to sound, you know, condescending or rhetorical, but he's like, wait a minute, sometimes you're like, did I just get that? Yeah, he really screwed himself up.
How's that different than reflection?
I'm trying to clarify a statement. You know, ask the patient to help you understand. You need to eliminate confusion. So, or you know, am I understanding this appropriately?
Isn't that kind of what reflection is?
They're close. It's just be careful. Just be careful between the two. Because the reflection, you're echoing back, right? This I'm saying is like, I'm understanding. I'm not just echoing it back. I'm making sure that I understand it is what you're doing. You know, versus that, okay, so I understand it correctly tonight. You did about a gram of cocaine. About 3 hours later, you start having chest pain versus like, wait a minute, you actually did the whole gram tonight. And then, you know.
So it's just in the wording.
Yeah, it's, you know, like I said, the clarification is for you, not for them. Confrontation, focus on a particular factor. Sometimes you have to just get there and say, you know, were you doing any drugs or alcohol tonight? Okay. Did you do anything else? Have you thought about hurting yourself? You know, the confrontation is pretty, obviously you're dealing with more sensitive questions at that point. Sometimes they're not. I mean, a lot of times it's like, okay, you're having a heart attack. We need to go now. Interpretation, state your interpretation of the events. That is, link events, make sure associations. And again, like I said, you know, so if I understand this correctly, again, that one can actually blur into reflection. You know, it's not just echoing back, but saying, okay, I'm making sure that let me say, if I understand this is what happened, this is why you're feeling this way. But all the information you've given me.
So it's kind of like you reflect off everything they told you, and then you start to put it in your own words. What's the process?
Kind of like a grand summary?
Yeah, like a summary of kind of what's going on.
Right. And if I don't understand it and I'm trying to understand it, then I'm clarifying from you. So explanation, share factual and objective information related. Yes, a knife can cause, obviously yes, NMI, you obviously have an occlusion of one of the coronary arteries, and that's what causes the chest pain because your heart becomes ischemic, obviously, which means lack of oxygen. And at that point, we have to do this. Summarization, briefly review the interview. So woke up this morning, this is what happened, you went outside, you tripped over, you fell on top of the dog. Next thing you know, you woke up, your family saw you have a seizure, and this is kind of where we are now. And then this is why you called, because you started doing all this vomiting and tearing up and salivating. Okay, I can do that. So, again, ask open-ended questions. And see, a lot of these all interlock with each other. It's just like I said, sometimes it's kind of keep in mind there are ways, or keep in ways to differentiate the two. I mean, obviously one can be used for different situations to link each other, but just remember the different terms, okay? Interviewing traps, false assurances, am I going to die? No. That's kind of a bad thing to say because everybody dies. Am I going to be, in fact, I remember one guy, he was a minister, he was having a heart attack. He's like, he asked me if he's going to die. He's like, I'm going to try everything not to, but I don't know. It's one of those tough things to do, but some things to say, but sometimes you just got to be kind of that honest of, hey, look, this is what's going to happen. Giving advice, be very, very careful with this, because if you give advice and you're kind of taking a provider role at that point, and you could be held accountable for that advice, just sit there and say, obviously always kind of give that generic, could be your best interest to probably go to the hospital, be seen by a physician, and the only time you ever really give advice is saying you're going against medical advice, which would be go to the hospital, be seen by a physician, da-da-da-da-da. But you don't want to sit there and say, oh, no, you're fine, just go get some, you can actually just go get some terry strips and you can suture your own head or do this. You don't want to put yourself out there. Some people will. But actually, I've seen people, and they're like, yeah, I'll be fine, they're just they can do that. But power trips, again, that's kind of an impression. If you come in, with a power trip, people are going to see it really quick. Would be a good example of avoidance language. That didn't really happen, did it?
Yeah.
You sure about that? Now let's actually talk about this here. Okay, distancing would be a good example of distancing.
Changing subjects?
Yeah, changing subjects, even more simple things.
Like moving away from
Moving away from the person. Okay, professional
On
jargon.
our side or their side?
Your
They're
side.
moving away or we're moving
You're
away?
moving away.
Okay.
Yeah, this is, interviewing traps.
This is our part of it.
Yeah. Professional jargon, again, like I said, we could sit and talk in medical terms all day long, but nobody really wants to half the time, unless they really need to. Talking too much. It's actually kind of reading years ago. If anybody ever wants an audience, they always go see a doctor. Now they just call us. So just to remember, we're there for them, kind of thing. And of course, talked about interruptions and why questions. And why did you think this was a good idea? Just too many why questions. Really, just too many why questions. Difficulty communications situations. Children, obviously, just depending on what level and cognitive level they are at that time. Again, we kind of generalize what children ought to be, but again, they can kind of fluctuate. It could be also mental development impairments, or just some people just develop differently and slowly for whatever reason. Elderly, obviously, we have the decreased senses, especially hearing, and like I said, they also have decreased sense of pain. So, what's going to be chest pain for them, maybe just this uncomfortable feeling right here, or not feeling right. Sensory impairments, the blind, the deaf, or both. how do you communicate that? I mean, with the deaf, it's always good to have something to write on. You can write back and forth to each other. The blind, it's just you got to kind of touch and talk. This is what I'm doing. This is what I'm doing. This is what I'm about to do as you're moving along there. Language barriers. Hopefully you can find an interpreter. If not, just understand you got to err on the side of caution. You can't interpret the language, even if they are alert and oriented. You can't prove it. So a lot of times these guys will just take it for a ride, and if they get angry and upset, and most of the time most of the time nothing ever happens of it. But it's kind of like him pulls you inside. It's like, how was I supposed to know this person was oriented or not? I can't speak Chinese. But cultural considerations. This can depend how culturally influenced area you are. Like I said, if you're kind of dealing with some more of the Asian cultures, you might sit there and see, the male of the household not looking at you or speaking to you, or if they do address you, they may not really look at you, kind of a thing. Or it just depends, But uncooperative patients, that's always kind of the given. Problem with uncooperative patients, it's trying to rule out, is there something really going on? That's what the tough part is. So, any questions?
On the giving advice part, if they're, like, say, okay, I'll just tell you, my ER rotation in basic, I was triaging. And some guy comes in and his blood pressure is a little high, and I was like, yeah, your blood pressure's a little high? He's like, yeah. I was like, you been to the doctor for that? Yeah. You give you medication? Yeah. Like, you're not taking it, are you? No. I was like, think you should? Yeah, probably. Is that all right? I mean, you just kind of call them out on it. I mean,
But that's more of a confrontation. That's more of a confrontation than an advice.
I mean, it's not something that they're not already taking. Is that kind of where the difference is on the giving the advice part?
The advice is it gets more tricky when it's something to the effect of, oh, no, just wash it out with soap and water, or it's just, your burns will be fine. Just, you put, butter on it, and I mean, you laugh now. Oh yeah, this will work, or just get some burn cream, everything will be good, and you don't need to go see a doctor. That, like I said, it's something that's going to come back, that can come back on you. Something like that, you're just being more, you're confronting him, saying, hey, this is probably what you ought to be doing for your own benefit, but, he's maybe talking to an alcoholic. It's like, no, if you just cut down to a drink a day, you'll be good. That's the big thing I say with advice. You don't want to say something that they can sit there and say, well, this person told me this, because they're not going to look at it as advice. They're going to look at it as, you are actually giving me some true, validated medical advice, and when you're really giving kind of your own personal advice. So anyway, there's Dr. Greenberg's email. So if you have any Star Trek questions, please feel free to email him. I encourage every class to do so. And say, huh? He won't make him mad. No, not him. But just sit there and say, hey, I did saw the therapeutic communication lecture over at Temple, and you did a lot of Star Trek imaging. Just ask him random questions. I've always been waiting for a class just to all send him emails one day and say, what's this all about? Well, you left your email there. They wanted to say hi.